Welcome to Your Anxious Child, 5-Minute Solutions, a podcast dedicated to providing practical advice and support for parents of anxious children. This advice is informational in nature and not a substitute for a consultation with a licensed mental health professional. And now, here's your host, Dr. Edward Plimpton.
Welcome back to Your Anxious Child, 5-Minute Solutions and interviews with experts. Now, every parent, every one of you out there has to make a judgment call when your child complains that their stomach hurts before school and they want to stay home. Is this a sick stomach or is this a worried stomach? Both can feel exactly the same. And this is almost an easy kind of judgment call to make. And then there are other conditions that children can kind of develop, such as Crohn's, colitis, celiac disease, that have a distinct structural basis that in many ways can be so challenging to negotiate. Fortunately, today, we have somebody who can help us understand and untangle this mess. Dr. Navidi is a clinical psychologist. He runs a practice in the DC area called GI Psychology that is essentially an online service available in all 50 states for consultation and treatment. So, Ali, thank you so much for talking with us today. And please tell us a little bit more about yourself, please.
Well, it's a pleasure. It's good to meet you today, Edward. And I've heard really good things about the podcast. And I'm glad to be here. I spent a good portion of my career working in private practice in the DC metro area. Over time, I developed a specialty in terms of working with patients with GI concerns, chronic pain, and then complex medical situations. I primarily worked with, kind of the older kids, maybe 8 and up, and then a lot of adolescents. And I would see adults as well, but it was mainly adolescents. Um, and and often I was working in conjunction with a gastroenterologist in the area. They started referring a lot of their patients because there are a certain class of GI conditions called disorders of gut-brain interaction that are extremely common. And unfortunately, very, very few people are trained to be able to treat these conditions. So I found myself a bit alone in the area. And this is an area with thousands of therapists of various kinds. But once I was full, I didn't really have any place to send these patients except for very specialized university medical centers that already had themselves huge wait lists. So about 5 years ago, myself and another psychologist started GI Psychology, and the vision, the mission is to increase access across the country to these very specialized forms of treatment for these disorders of gut-brain interaction. And then as well, as you mentioned, some of the more structural conditions like inflammatory bowel disease, so Crohn's and colitis, and just in general, helping those patients who have various types of chronic pain.
So it would be, I think, helpful if you could give us kind of the landscape of kind of GI issues and just talk about this gut brain access that's so kind of central to your work.
Yeah.
You know,
So,
what are the kind of problems that fall under the domain of your practice and interest, and tell us a little bit about the gut brain access, if you could.
So for the most part, when it comes to GI conditions, there's kind of two main categories. There's those conditions that are structural. So, for example, inflammatory bowel disease, as I mentioned, um, Crohn's and colitis, something like celiac, where there's inflammatory responses to gluten, or Crohn's or colitis, where there's inflammation, there's damage to the intestines happening. So we support those patients, but we can't say that we're going to offer a cure for the underlying condition. We support them with their chronic pain. We support them with their psychological resilience. And we've even partnered with the Crohn's and Colitis Foundation to offer nationwide an especially designed IBD therapy group. And so we offer that across the country. So that's kind of one side of the landscape where there's more structural conditions. And we're in a more supportive role. We're helping them manage pain, discomfort, anxiety, depression, adjustment to the condition. On the other side is this category of GI conditions that used to be called functional disorders. And I think as psychologists, we kind of know functional over time developed a little bit of a bad reputation and got a little confused with the idea that it's all in their head or they're just making it up. And I think maybe it was about 6 years or so ago, something like that. The Rome Foundation, which is the overarching body that deals with these disorders, renamed it to disorders of gut-brain interaction. And they include about 20 something different disorders. Most commonly known would be irritable bowel syndrome. Um, there's another that's called functional dyspepsia. If you think of irritable bowel syndrome as kind of lower GI, they're having pain and they're having diarrhea or constipation with IBS. Functional dyspepsia is more kind of upper GI. There's slowed motility. Motility is how fast things are moving through. Um, there's often bloating and a lot of discomfort. There can be nausea and often there's loss of appetite. And so some of these patients are losing weight. So that's like a couple of those disorders. There's also something called gastroparesis that was actually recently added to the list of disorders of gut-brain interaction. And that's where they actually see the stomach have delayed emptying, meaning normally when we eat, things move through us at a certain pace, whereas in gastroparesis, that pace can be dramatically slowed. So they do these gastric emptying tests and they don't find normal transit. The one probably most relevant to kids would be what's called functional abdominal pain. They're just having pain in their stomach and people just don't there's no structural cause. They run all the tests, they don't find anything, but there's still pain. That's probably the most common one that I would treat when I was treating, 8 through 12-year-olds. That was a common one. And then there's various nausea and vomiting disorders. So it can be really difficult things for patients to deal with. I know I didn't go into the gut-brain axis and start talking about that yet, but I felt like I talked a lot. So I want to pause for a second.
Well, certainly emetophobia is one that comes up a lot in kind of the pediatric practice I work in, where a child has seen somebody throw up and then they get worried that they're going to throw up and stuff like that. And that, kind of relates to something you refer to as visceral hypersensitivity.
You got it. You got it. And by the way, emetophobia, I'm so glad you brought that up. I know that's an expertise of yours, And it's actually super relevant to this discussion because I don't think I've met someone with emetophobia who didn't also develop a disorder of gut-brain interaction. And I'll give you just an example, because what tends to happen is it's kind of like a chicken or egg thing. Let's say a kid either witnesses or experiences vomiting. They don't react to it well, and they start to become hypervigilant about vomiting again. And that can be externally directed and is often also internally directed, meaning they're vigilant to the outside world, they're watching and they're making sure there's no problems anywhere, right? Um, in addition, they become, and I'm sure you're familiar with this, internally hypervigilant. And that means they're scanning their internal feelings for anything that might indicate that they might have to vomit. But what that sets up is a negative feedback loop. So the more that they're anxiously attending to their stomach, the more they're actually sending stress into that stomach. Because, like you mentioned, there's something called the gut-brain axis. And in very simple terms, it means what happens in the brain. Although the brain and gut have a very special relationship in the body, and what happens in the brain affects the gut. What happens in the gut can affect the brain, and it's the interaction between the central nervous system and the enteric nervous system, and that's the nervous system in the gut. There's more neurons than in the spinal cord. It's considered by some like kind of the little brain. And so all that stress from that vigilance that that poor kid has gets sent into the gut, and then they start feeling more symptoms because of that. And then, like you talked about, that visceral hypersensitivity, because they've been primed to already see that gut as a threat, the brain amplifies and distorts those signals. So it can turn, maybe a little fullness into pain. It can turn it into nausea. It can transform those feelings, and then they're just freaking out even more as they feel those amplified feelings. So let me pause again. Sorry.
But, you know, it's like whenever the brain says, "Uh-oh," it freaks out the stomach. And what's the stomach know? The stomach doesn't have any eyes. It can't look around. So it just gets this kind of uh-oh message from the brain, and it says, "Hey, time to shut down business. There's just no time to be doing any digestion. We have, we're closing up shop for the day." And then you have that discomfort.
I love the metaphor. I love the idea that the brain doesn't have eyes. It doesn't know any better. I love that.
Right. The stomach doesn't have eyes.
Yeah, yeah. Sorry.
Right. No, it doesn't have
Yeah,
any.
the stomach.
No, it's just getting this off on a message. Right.
Right. It's just like the brain is saying like danger, danger. There's something bad happening here, and the stomach's like, okay, let's either start shutting things down or start speeding things up, right? To like clear us out. Neither of those things is what the patient actually wants to happen.
Right. Um, is there, there's some conditions that make it more likely that you're going to kind of develop this category. And I wonder if you could just kind of, tell us what sort of conditions are, you know, frequently go along with these sort of complaints or problems.
Yeah. So let's say if I'm speaking to clinicians, I would say to them, look, if you've got patients that have anxiety disorders, it's probably good to be asking about GI, right? If you've got patients with a history of trauma, it's good to be asking. If you've got patients that are on the autism spectrum, it's good to be asking. And finally, if you've got patients that have had or currently have any kind of eating disorder, it's good to be asking because those 4 categories, so anxiety, trauma, autism spectrum, eating disorder, have much higher rates of disorders of gut-brain interaction.
It strikes me as you say that, that those 4 conditions also, um, may be different pathways to getting, this, functional GI kind of problems. So, for example, if you're born with sensory sensitivities from the get-go,
Yep.
you're just, um, you are, where you over-register to begin with those, symptoms, then you have a risk condition,
Mhm.
for that. Um, and of course, if you're an anxious person, you're going to be, just more hypervigilant to begin with.
Exactly. Yep.
Um, and you've also, made kind of an interesting in other kind of podcasts, made an interesting kind of comment about kind of trauma with regard to the structural kind of problems, which is that, if you are somebody with Crohn's, you have a history of experiencing kind of pain. And it's almost like you develop a trauma response to that.
Yeah.
This which I thought was quite an interesting kind of comment. And maybe we're getting a little off talking about this.
No, I think we're on. Yeah,
But,
I think that's a great question because, so the trauma response so, for example, Crohn's or ulcerative colitis can be very disturbing conditions to have because these patients have, these periods of calm and then very unexpectedly can shift into danger where they're vomiting, they've got diarrhea, they, have intense pain, they need to go to the hospital, they need to go to the ER, they need treatment, and there can be very little warning between those. They call those flares. They can have these flares. I can't imagine a kid alive who, is gonna respond to that without some level of trauma. Right? Just going from being healthy and feeling good, eating whatever you want, to then that intense discomfort, pain, going to the hospital, and then knowing that that is always a possibility. And what that leads to, well, it leads to a lot of things, but one of them it also leads to is amongst IBD patients, so inflammatory bowel disease, um, there are much higher rates also of disorders of gut-brain interaction. So, um, because of that hypervigilance that they develop towards their GI system.
it's it's so kind of challenging for these kids because when you can't take your body for granted,
Mhm.
you are going to develop a sort of, in my experience, often a precocious self-awareness
Mm.
because you cannot take your body for granted. You can't just sort of, just go about your business, carefree, relatively speaking. You have, in some way, it's in the back of your mind. And on one hand, that can make this group of kind of kids actually unusually empathic and sensitive. But on the other hand, it also primes you for, in your phrase, visceral hypersensitivity. So it's
Yeah.
a very double-edged sword.
You know, I never thought about the plus side, the potential plus side of having these kinds of conditions that increased empathy, understanding of other people's distress. But I would say from my experience, it's true. I don't think I ever put it together like that. That it is a double-edged sword. Um, yeah, I appreciate that.
I had, I know a young, adolescent who with an inflammatory um, bowel disorder, come to the defense of another child who had diabetes when somebody was making fun of him. Very empathically, standing up and really standing up for this kid who had diabetes, and another peer was making fun of him. You know, it so
Actually, there's a similar, weirdly, just last night, I was meeting with a patient with IBD, and there was a similar example of just that increased empathy for others that have chronic medical conditions. Yeah. that-
so so fortunately, there are some things that we can kind of do about this. Um,
Yes. Uh,
you know, um, but interestingly, when we're dealing with anything that kind of on the spectrum of kind of anxiety, um, there is some counterintuitive, um, issues that come up in straight anxiety. It's counterintuitive that reassurance is often not the thing to do, because as parents, what do we do best? If the child's distressed, we provide comfort.
Right.
And so when you're in the land of anxiety, where a child may be going endless reassurance questions,
Right.
you need to kind of develop a different approach. Um, and that, but that's true of kind of the stuff that you're dealing with. But there's an added kind of dimension where it's a little counterintuitive in where we start. So where do you recommend that we don't start with this kind of domain of problems?
Mm. I think uh, I think one thing that people sometimes get wrong is they treat it like it's just anxiety. So whether it's patients, or the parents, or whatever, or um, clinicians, they think, oh, this is just caused by stress, and stress maintains it, but there is absolutely a powerful mind body component happening here. The pain is real, the discomfort is real. Um, and the physical changes that it causes are very real as well. So so if people just treat it like anxiety, and kind of go very traditional and say, like, okay, we're just going to use our basic CBT techniques here, and we're going to talk to them about their automatic thoughts, and you might make a little bit of progress, but there'll be a lot of patients you're just going to hit this brick wall, because they don't always have accessible thoughts. There aren't always super clear targets for your exposures and things like that. Um, that it needs that a deeper layer of understanding the mind body component, as well as the anxiety components, as well as any trauma components that are there. So I say that because I've seen it so many times where gastroenterologists will say, "Oh, CBT helps for these problems. Let me just send them out into the community and see a CBT therapist." They don't do badly, but often they don't get the help they need.
So would it be fair to say that one of the problems here is that, to put this very informally, the stomach talks in sensations. It doesn't talk in words. And that one needs to, in some way, develop a different relationship to the sensations in your body.
Yeah,
The thoughts are important,
yeah.
but um, but we're really dealing with a miscommunication about the meaning of sensations.
I think that is sign- a significant part of the treatment. Of course, it's not all of it. There's other aspects, but that is so important. For example, to change their experience of their interoception, their sense of the feelings in their body from one of distrust to that, going back to that word we talked about, right? Safety, going back to a sense of safety. And that can be one of the most profound changes that a clinician can help those patients make.
So, um, I'm not sure I kind of phrased my question quite clearly enough before, but um, look, we've got a problem with our stomach.
Yeah.
So, dude, let's just kind of go with the diet. I mean, we need to change the diet. I mean,
Yeah,
it's a problem with the stomach, and what's the deal here? I mean,
absolutely.
we should,
Yeah.
and lots of good diets. We should. That's where you should. No,
Well, just like life, it's never simple. It's like there are diets that can help with, let's say, IBS. Um, so of course, like you want to get this medically looked at. You want to rule out the danger signals, the cancers, the ulcers, the inflammatory disorders, you want to rule these things out. But once you have, and for most kids, it's not going to be one of those things. It's going to be a disorder of gut brain interaction. Then, unfortunately, it makes so much sense to focus on diet. And all it does is just dig them deeper into the hole. Because the more they focus on the diet, the more they're reinforcing the idea that there's something wrong with the stomach. And in fact, there's nothing wrong with the stomach. But it's such a seductive hole to go down because they're going to feel short term relief. As anyone working with anxiety knows, the road to hell is paved with short term relief,
mhm.
right? Like those little reassurances or those little avoidances, right? Well, it's very similar with food because let's say they're just having a bad day with their stomach and they happen to eat pizza. So now there's a link between feeling bad in the stomach and pizza. So the brain is like on alert. So next time they eat pizza, the brain is extra vigilant. And we already have established, right, when we have that type of anxious vigilance, that's going to disturb the stomach more. So now they're eating that pizza, they're vigilant, and their stomach is being disturbed through their stress and their anxiety. And that's confirming that now pizza is bad for them. And so what happens is over time, by the time they come to like my clinic or see me, they've got this massive list of foods that are bad. And each food that they determine that's bad has reinforced the idea that there's something wrong with their stomach, which is reinforcing the problem versus the idea that there's a problem with the nervous system and how it's interacting, the enteric and the central. So it takes them down the wrong path, and it can be a path that people get stuck down for years because of that focus on food.
And well, we always want to be attentive to potential structural problems and always be willing to revisit that issue. There is a simpler, there is a relatively simpler approach to take to this that doesn't necessarily have a lot of side effects, which is your combination treatment of hypnosis and cognitive behavior therapy.
Yes.
And I think it would be great if you could talk about the contribution of hypnosis to this issue and the separate contribution of cognitive behavior therapy.
Yeah. So and it's a good order to start in because clinical hypnosis is sadly misunderstood. Um, it's an amazing clinical tool, but it's been unfortunately uh, connected repeatedly with what I call entertainment hypnosis.
Mm.
And we all know entertainment hypnosis, it's the mind control, and every year there's a new movie out that is very sinister and shows terrible things happening because they're being hypnotized. So that's a lot to fight against. Like we're fighting against Hollywood here. Um, but on the clinical side, you've got, go into PubMed, just type in the word hypnosis, see how many things come up. You'll get thousands of references because I I could argue that it's probably one of the most studied psychological phenomena that exist. It's been looked at for such a long time. So many smart people have researched this. And so when we look at just hypnosis for GI conditions, we've got over 40 years of research, hundreds of studies have been done. This is very solid stuff. Um, so what the hell is it, right? If it's not magic and witchcraft and mind control, um, it is essentially um, deliberately going into a state of consciousness that is called trance. Um, and trance is something that we all experience throughout our day. It's a very natural, normal human state of consciousness. When we get lost in a book or a movie, you see a kid, and if they're holding a phone, then we know they're in some level of trance, right? When we lose time because we're distracted by something, so there's so many examples of trance happening, and it's natural and it just happens spontaneously. And for hypnosis, we're just teaching them how to enter that state deliberately, because when they're in trance, people have the capacity to have much more of a powerful mind body connection. That's one of the reasons we like trance. There's a lot of others, but that's a primary one for this discussion.
So, how does one, for GI problems, direct the nature of the trance? Um, it how do you kind of focus, because there are any number of ways in which you can kind of focus the kind of experience of trance. And
Yes.
how do you do that for GI problems?
Well, just like there are many ways to focus the nature of trance, there's many ways to focus the nature of trance to help with GI problems. But we can give some examples. So there's one phenomena that we can elicit in trance, which is kind of an anesthesia effect. Essentially, we have the capacity in trance, depending on their skill and their training in trance, because trance is a skill like any other. Um, we can teach people to turn down or turn up their sensations. And and so as an example, we can take that pain, let's say that's in their stomach, and just within, let's say 10, 15 minutes, turn it down to almost nothing. And that does a lot of things for that patient immediately. One, it gives them a tremendous feeling of control, because when people can control something that's been scaring them, it doesn't scare them as much. Um, but it also begins to set the stage at a more emotional level, that they are safe, that this is not that there's something horribly wrong in their stomach that's going to kill them, but that it actually is a product of their central and their enteric nervous system. So they begin to have that belief, they begin to have much higher sense of control. So safety and control, they go together really nicely. So that's one example of how you might direct that trance, by teaching them how to reduce their sensations of pain.
And it's important to note that, interestingly, children in the 8 to 12 range are, potentially particularly good at, hypnosis.
Yes, yes, absolutely. So it's so fun to work with kids at around that age, um, because you can make changes so quickly versus, let's say, an adult comes in to see me and they've had 20 years of IBS. Um, we can absolutely help them, but it might take a little bit longer.
Sure.
Versus a kid, you know, that's where you get these 1, 2, 3, 4 session cures that just seem so like miraculous. It's because kids are so good at hypnosis and they also haven't had all those years of reinforcing an identity, the habits, the mental habits, all these other things of the problem. So they're less kind of rigid and they're really good at hypnosis.
So in the second, contributing therapeutic tool is um, a variation on cognitive behavior therapy. And um, I'd be interested in terms of how it's tailor made to GI problems that, maybe say separate from how you would deal with panic disorder.
Yeah, I'd say there's a lot of similarities and even even with the interoceptive exposure that's there with panic disorders as well. I think it's understanding one of the differences is just understanding where the anxiety tends to hide, if that makes sense. So, what are the types of dysfunctional thoughts, distorted thoughts that these patients will tend to have? What are the types of things that they avoid? What are the types of safety behaviors that they engage in? It's going to be slightly different when it comes to each type of disorder of gut brain interaction, whether it's IBS, whether it's cyclic vomiting syndrome, whether it's chronic nausea. You're going to find different types of thoughts, different types of behaviors that you want to go after. But I'd say probably of all the different forms of anxiety that you might treat with cognitive behavioral therapy, maybe panic disorder could be the closest kin to it because of that very strong somatic component.
So, right. You've also kind of talked about actually a very basic, so there's hypnosis and cognitive behavior therapy, but you've also kind of mentioned, in other, places where you've talked or written about going back to just a very simple fundamental, which is the value of kind of breathing and kind of meditation,
Mm.
um, which, if as a fundamental kind of way of facilitating rest and digest.
Yeah. Yeah. So if you kind of want to keep things simple, like, okay, our goal is to shift the nervous system from fight or flight to rest and digest. And what are the ways to do it? Well, one of the foundational ways to do it is through the breath or through kind of being still and being mindful. And the problem a lot of patients come in with, as you know, because you treat a lot of anxiety, um, is some of them are actually anxious about their breath,
Sure.
right? Some of them are often anxious just to be with themselves in silence, to
Mhm.
be with their own thoughts. They don't know how to manage that. But you think about how profound is that? There's something so basic to the human, which is breathing and thinking are causes of anxiety for some patients. So So consequently, it's such a profound intervention to shift that from a state of anxiety about your breathing or a state of anxiety about just being with your own thoughts to feeling comfortable and soothed by that. It's a pretty profound intervention because these are things that are so fundamental to being human.
Right. And we need so many different ways of learning that feelings are transitory.
Mm,
And the breathing actually is one way of kind of getting that with your breathing, you can kind of alter your, you know, physiology and indicate that, yeah, actually, no, feelings can come and go.
exactly, and I think, and I would guess you probably utilize this, but utilizing the breathing with a sense of mindfulness also can give you that same effect. So now they're aware of watching those feelings change as their breathing is shifting their internal state is very powerful.
So we are almost out of time. So I just want to touch base with you in terms of whether there's anything that you feel we should mention that we haven't. And if not, then, how can people access your GI psychology um, clinic?
So I feel like I'm a bit of a broken record with this message, but I, I feel like there's value in repetition. And
I I think redundant learning in so many ways and redundant is important.
so
Absolutely.
my closing message is often this, which is, if you're suffering from a GI condition, if you've got family, friends, children that are suffering, and you've gone and gotten things checked out, and it's none of those structural issues, um, you don't have to live with it. You don't have to live with your IBS. You don't have to live with your dyspepsia or vomiting or nausea. The treatments are there, they're available, and they're very effective. Research shows 70% are going to reach their treatment goals with just one of the hypnotic protocols. And that jumps up to about 80% for kids and adolescents. Um, the treatments are there, they're effective, they work, and it's science. It's not just, witchcraft. So, um, we've worked at GI Psychology to be a resource available all over the country because nothing else like it exists. There isn't a resource like this, so we've gone through the trouble to make that. And so I'd encourage people, they can go to the site, they can get a free consult and ask all the questions they need. They can read about, the articles and resources, but just don't accept that you or your loved ones have to live with these problems.
Great. Great. Well, great. Well, thank you so much. This has been so helpful and informative.
Well, thank you. It's been a pleasure talking with you, Edward.
Thank you for listening to Your Anxious Child. Please leave us a rating and review in iTunes to help us get the word out. If you'd like to learn more and find additional resources, visit us at edwardplimpton.com.